This is hopefully going to be one where basically Bob and I are going to say very much the same thing. It's a challenge, but it's a lovely challenge to have. The bottom line is, in relapsed refractory disease, what are best options and how best to sequence combinations? And I'll lead by saying that really truthfully right now, I think it's fair to say we don't know. The good news, though, is that we have lots of options to explore, and there are a number of trials. And what I want to try and do is show you perhaps some guiding principles for you to take home to your practices, and just to realize the really good news is that in the toolbox there are now a lot of things we can use. And for that excellent last question from Mark, I think the point is that you can now select your agents. So if you have someone, for example, at cardiovascular risk, you can spare them carfilzomib. Conversely, if you have someone with neurotoxicity, you've got great other agents that you can use, such as carfilzomib, to meet that challenge. So with that in mind, these are just some sort of background slides. There is simply in your deck, so I'll move through them very quickly. I love this slide simply because it's not only very attractive to look at, but it summarizes the complexity of this, and it's a lovely review from Ken and Antonio a few years ago, but essentially it emphasizes the construct that the complexity of this illness is fascinating and very important, and our best drugs target not only the tumor cell but also the neighborhood. What I also want to bring to your attention here is the bone microenvironment as a vital part, not just only the bone marrow stromal cell. And the big missing piece to this diagram, given that it was published back in 2011, is the immuno-oncologic repertoire that we realize is now so important. So when we think about general considerations in the treatment of relapsed refractory MM, I just want to show you a couple of sort of guiding lights. Essentially, in terms of patient and disease characteristics, Ed's touched on it. Don't forget frailty. The ability to deliver continuous treatment matters, and therefore the tolerability of any regimen really matters. And similarly, we do need to consider what components of initial or prior treatment there was, and therefore, can you revisit them? Yes, you can. And obviously, the important message is, if you do revisit them, there's a strong rationale for combination approaches, which I'll come to in a minute. I want to show you some very positive notes. This is a lovely paper from 2004 from Shaji Kumar, who's done really instrumental work here, but this gives you the sort of doom and gloom that we saw years ago. As you can see, everything just got worse over time and the survival was dismal. The really important message is that there is still poor survival outcome after IMiD and proteasome inhibitor failure, but the really good news is that in the relapsed refractory space now, we're seeing much more durable outcomes, as reflected by studies like Aspire, like Endeavour and others, and that's all good. What's very important to recognize, though, is that we have choices, and that's really my point to you. You're going to hear very nicely from Bob about KRD and CARPOMD, etc. I'm just going to illustrate that there are other things that we can reach for as well. So a couple of thoughts here, and this is all going to be on the website for you to have as a PDF or however Chris is going to do it. But the bottom line is that you can think about your treatment options in this context. I don't want to rule out also transplant. Salvage transplants, particularly in first relapse, clearly have a role in the younger patient. Allogeneic transplant, a challenging area. The funny line in Europe is that allotransplant is a poor man's Pomalidomide, which I think is somewhat ironic. But having said that, there is a certain amount of truth to that. I would only argue, though, that allotransplant hopefully will see what autotransplants has seen, which is the rebirth of its efficacy in the context of novel treatments and more targeted immuno-oncologic approaches. This is a strong rationale for combination strategies. The big thing that's missing from this diagram is, of course, monoclonal antibodies. But it really serves to illustrate the point I'm making, that you have choices, and think of course, now, what do we have available? Well, obviously, we have an armamentarium of proteasome inhibitors and IMiDs. We have HDACs approved and in development, such as the AC1215 and 241 compound, that are very promising. And, of course, you always have your backbone agents in the form of your chemotherapeutics. This is the NCCN guideline, which I think is very helpful, and I show it to you simply to give you the spectrum of available options. So again, I think genuinely Bob and I will absolutely agree here. CARPOM, KRD are excellent choices in relapse. My game is simple, my remit is to simply make it clear to everyone that there are choices. In my own practice, to be honest, I'm less of a fan of the more intensive chemotherapeutic regimens. The responses that we see from such drugs, such as combinations such as DCEP, tend to be transient. They are useful to buy you a little time, but in my experience, the toxicities are always a challenge. So, what are the takeaways from ASH that give you the options for the future? Well, I think the very important message is summarized here. Targeting protein degradation, the whole concept that we have second and now third generation proteasome inhibitors available. Carfilzomib and Ixazomib now approved, Marizomib in development. This is a very interesting compound. It's an irreversible binder of the proteasome. It hits beta 5, beta 1, and beta 2. And in combination with pomalidomide, it's exquisitely active, and actually Andrew Spencer presented a beautiful paper at the IMWG showing this activity of this combination in very refractory or quadruple refractory patients. Now, in the context of newer agents, just want to emphasize the choices, and we already have FDA-approved panobinostat. I mentioned these previously. There are new chemotherapeutics coming again as part of clinical trials that are very exciting, but clearly the real game changers, in my view, in the last couple of years have been the monoclonal antibodies and the checkpoint inhibition combined with immunomodulation. This is a schematic just to illustrate the science behind the proteasome inhibitor story. I want to bring your attention to one class of new drugs coming, the DUB inhibitors. There's an excellent trial led by Ola Landgren at Memorial, which we're actually partnered with him in doing, which is very interesting with this new class of drugs. A couple of points about Ixazomib. Again, I think that we're blessed with choices. Carfilzomib is an excellent drug, very potent, and clearly confirmed in randomized phase 3 trials to be effective. The good news here with Ixazomib is the same story as emerging. And in that context, this is the phase 1 data, weekly versus BIW. Make an interesting point here. I would argue that it's very likely we will revisit Ixazomib twice a week. I think from the randomized trial I'm going to show you in a minute, there's a very interesting pattern to the separation of the curves for progression-free survival. I would emphasize that when our twice-weekly study, we showed a similar overall response rate and manageable toxicity to the original study, or rather the parallel study run by Shaji. We published both these papers back-to-back in the same issue of Blood for the weekly. And I'm emphasized that because I've had a couple of patients anecdotally on being given drug in the context of practice and commercial availability, where we've been at weekly with an IMiD and we've converted to twice weekly and got response when we weren't getting it weekly. So this is an area that will be probably revisited. The trial that drove Ixazomib's approval, led by my colleague Philippe Marrow, was presented at ASH in December, and I'm very pleased to tell you it's currently now in press in the New England Journal. And the bottom line is Philippe showed beautifully in this study basically response rate differences in favor of the Ixazomib lenalidomide dexamethasone combination, and these were significant. And very importantly, in the same context, there was a progression-free survival difference that emerged over time. The thing that's got everyone interested is what's going on here. Why did it take up to 9 months for this to start to separate? My own bias is that perhaps there is an opportunity to explore more potent proteasome inhibition with a twice-a-week schedule, very similar to the sort of bifurcation that I know Bob's going to show you for KRD. What's very interesting here is you saw this later effect, because obviously patients can stay on Ixazomib for prolonged periods of time. There are also patient selection characteristics to the trial that may be relevant here as well. But having said all of that, the difference is significant at approximately 6 months and very commensurate with what we've seen. We have to be careful about cross-trial comparisons, but obviously with KRD, it's a 9-month difference. With IRD or RID, it's 6 months. Is that clinically meaningful? Perhaps. I don't think we really know, though. And having said that, though, both are good in my view and exciting for the future. What's very interesting is the quality of life scores are very favorable as well. And the same is seen with KRD, I want to emphasize. So conclusions are basically that these next-generation proteasome inhibitor choices are very exciting in going forward. What's exciting about Ixazomib, of course, is it's all oral. And I would argue to the question from Mark earlier about how you choose your proteasome inhibitors, one thing we really did not see with Ixazomib was cardiovascular or other sort of vascular toxicity. There was no difference in thromboembolic rate, no difference in cardiac signal. However, in fairness, Ixazomib was associated with more rash, and there is a neurotoxicity to Ixazomib, but it is very manageable. Now, what about pomalidomide? I think obviously that's been a game changer. One really interesting aspect of the IMiDs is our better understanding of how they work, and that is a whole new area of excitement, and the immunomodulatory mechanisms involved are clearly key. The cereblon story is really a case of the more you know, the more there is to know. Do you not give it to someone who's a low cereblon exposure? Absolutely not. There's more going on. However, those patients who clearly do express high levels of cereblon seem to be those who may derive longest benefit, but it's a very interesting and emerging story. story. The POM data are very robust. I'll move through this quickly in the interest of time. Pomalidomide bortezomib dex is very exciting. You're going to hear more about CAR-POM with Jatin's work from Bob. But my point is that if you look, and again, I'll be very careful of cross-trial comparisons, but if you look at Joe McHale's work, looking with actually the Mayo group, led by Martha Lacey, what Joe and Martha have shown is that with weekly bortezomib and pomalidomide, this response rate, people often ask me, is this relapse refractory or newly diagnosed? It's really very exciting with an overall response rate north of 90%. I especially want to acknowledge my colleague Pete Voorhees, who led this study of ixazomib plus POM in the Alliance. We're very, Pete's been an extraordinary force in the Alliance, great contributor. And the bottom line is what Pete showed at ASH as an oral session was a very high response rate to this all-oral regimen in double refractory patients. So this is very exciting, and it's now going forward in the intergroup mechanism into a randomized phase 2-3 to hopefully get some form of approval platform for ixazomib POM. In that same context, when you combine POM with Mariz, it's very exciting, and I mentioned already that Andrew Spence has presented this data. In the laboratory, it's the most powerful combination that Dharminder has studied. This is Dharminder Chauhan in our laboratory, who's a powerhouse in the proteasome inhibitor space. And basically, the clinical translation of this has been equally powerful. What's really interesting about Marizomib is it does cross the blood-brain barrier, which, of course, you might say, my goodness, isn't that a problem? Well, interestingly enough, we seem to have found a therapeutic window. And what's also very interesting is it's actually seemingly very active in the neuro-oncology space as well. So arguably, you might see this drug, for example, become a proteasome inhibitor of choice for CNS lymphoma or CNS myeloma, for that matter, which we now see. What about the HDACs? Well, I think this has been an underappreciated space. The disappointment around Voronostat, I think, was premature. Panabinostat has come through. And I know there's a lot of controversy, but at the end of the day, I think this drug works, and it works well, especially if you're able to give bortezomib subcutaneously and weekly, and also find a dose that the patient tolerates. Moreover, I think it in combination with IMiDs is very exciting, and the rationale behind that summarized here for at least the proteasome inhibitor space. And I would emphasize also the next generation HDACs, AC1215 or ricalinostat, now replaced by AC241, which is more HDAC6 selective. And my colleague Nupa Raja has been leading studies in this regard, which we've participated in, and in combination with pomalidomide, the data are very provocative. In terms of PANO, this is the data I think everyone's familiar with, a progression-free survival benefit around 4.5 months, but our blood paper, which just came out, really showed that the benefit was substantial in the double refractory higher risk patients. And I just want to remind people that the PFS difference that we showed in the double refractory patients with panabinostat vel was actually 7.6 months, which I think is really important to share because people, I think, don't realize that. And when you appreciate that, it makes this platform very exciting. Last couple of minutes, when you combine antibodies, obviously very exciting. I want to make sure that people are aware that not only is there elotuzumab and daratumumab, but there's a very exciting new antibody from Sanofi. This may be qualitatively different to daratumumab, we don't know yet, but it's very active and at the same time well tolerated in the same way that both Dara is, and especially Elo. And the good news here is there are also other antibodies in the making, in addition to siltuximab, which we talked about earlier, which clearly has a role in Castleman's and other syndromes. But very, very importantly, there's a CD138 targeting antibody that I think could also show promise. This is just Dara data. I want to emphasize the combination of Dara with Dex. This is a combination study of Sirius, which is led by Sagalonio, and our 501 study. And as you can see, the response rates are robust. But when you add IMiDs to this, things go into overdrive. This is Torben Plesner's work in the 503 study. And basically what you can see is a remarkable response rate of 80% above. And what's really interesting is the recent results of the Pollux study, which in relapsed refractory disease shows an interim analysis highly positive for Dara-Len-Dex. That was published, or rather made public, just this last week. So in that note, when you add Dara to POM, what happens? This is from Achai Chari, who's done beautiful work from Mount Sinai, and Achai showing here very nicely a great response rate. So lots of exciting choices. I think we've already talked a little bit about Elo. I know Ruben touched on this beautifully earlier. Very exciting mechanism of action. lots of work behind it that underlie its activity. We updated Saga's original New England Journal presentation at ASH, and as you can see, the PFS survival benefit continues. And whilst there's not a significant survival difference at this point, there's a strong trend with a p-value of 0.025. And on that note, when you combine nilotinib with bortezomib, Antonio shows clinical benefit in this phase 2. One quick question to mention, and I say this only because it's in the context of debate, is that the genetic heterogeneity of this disease is extraordinary. And what we're showing here is that over time, mutational load per patient can change. And you can start with 4,000 mutations in one patient, and then after treatment find that they actually then have 12,000. My point of showing this slide is that as we think about combinations, it's going to be very, very important to recognize that the bigger net we throw around the disease, the quicker, probably the better. So I would argue that as we think about things like RVD, Pomveldex, KRD, K-Pomdex, I'd make a very strong argument for additional agents to be added to get over this kind of problem. Because at the end of the day, it's very sobering if you have a patient with 4,000 mutations at diagnosis and treatment, and then when they're relapsing, you find they've got 12,000. And that's essentially what that shows. So just in my conclusion, in the interest of time, I really want to just reiterate that people have choices. And the good news is that we have multiple to choose from. So I would think I'm essentially going to agree with Bob. KRD, KPD is a fabulous platform. I would just argue that we need to think also beyond that as we go forward. And this is an example of the new and exciting drugs in the pipeline. I want to conclude with this. Thank you very much.